Well, welcome everybody. Thank you for coming to the Osher Center for Integrative Medicine Grand Rounds. I'm Peter Wayne, the research director, and we alternate our grand rounds monthly to have a research grand round and a clinical grand round. And this month is going to be a research grand round. And I have the distinct privilege of introducing our guest and who's come up from Yale University and the VA system in New Haven, Dr. Anthony Lisi. And in many ways, Dr. Lisi really embodies what it means to be an integrator, having been a pioneer at the forefront of integrating chiropractic care into hospital systems. I learned a little bit more over dinner and this morning that Dr. Lisi had a stint through Wall Street for a while where I think he developed a lot of good organizational skills, but then he saw the light and decided to go to chiropractic school and became a chiropractor at Palmer Chiropractic College in California. And then he had a private practice for close to 10 years. Then he was recruited by the VA to become one of the first chiropractors, actually in a hospital first, and then the VA recruited him to start one of the first chiropractic programs in the VA as it was mandated, and I think he's going to give us a little more of that history by the government. In 2007, he was asked to coordinate the whole network of integration of chiropractic care along with other integrative therapies into the VA health system, and was and is now the director of the VA health administration system and chiropractic care. He's also an associate research scientist at Yale Center for Medical Informatics, and his specialties in the health sciences research. He also plays a very prominent role on a number of distinguished national and international boards related to this integration. So without any further ado, please join me in welcoming Dr. Anthony Lisi.
Thank you, Peter, and thank you all for attending. It's a real privilege to be here, able to speak to you this morning. I have no commercial interest to discuss, but the projects that I'll be presenting were funded by a VA and two private foundations. And what I'd like to do is discuss three sort of main areas about the VA chiropractic program. So how it was implemented in terms of the original rationale and some of the barriers and facilitators to implementing this program, and then trends in the use of chiropractic care in VA over time with some of the data that we know about its impacts and outcomes, what's been the result of adding this service to this large government healthcare system. And then some interesting preliminary data we have on associations with opioid use in chiropractic care. So this started with a legislative effort where veterans groups and other associations had lobbied Congress to open the doors for VA to provide chiropractic care. And it began in the calendar year 2000 with some limited use of VA purchasing chiropractic care in the community by sending some of its patients out. And that was really just a small step. And then in 2004, became codified as part of the standard medical benefits package and began being delivered at a small subset of stations in-house. The VA divided back at that time the nation into 21 geographic regions that we call VISNs, and the initial law required that VA would have a minimum of one in-house chiropractic clinic in each of its geographic regions. So it set a minimum threshold of 21 across the country. And on one hand, that shouldn't have been too hard because we knew that chiropractic care was commonly used in the US, so some of the studies show roughly 14% of the general US population, about 13% of the Department of Defense healthcare system, which is something that we often model when we look at VA health services. We knew it was in demand by veterans. There have been some work that showed over 75% of those veterans who didn't have access wanted to receive access. And we knew that many of the treatment options that chiropractors provide are part of guideline concording care. So it wasn't that VA had to research and sort of study the effectiveness of this as a new system. But yet there were some obstacles, especially back at that time. Chiropractic care was exceptionally rare in hospital systems. The OSHA Center was ahead of the pack in what was back at that time very, very rare, certainly in a large government system. We know that there are varying perceptions of the appropriateness of chiropractic care by physicians. And this was also a congressional mandate for VA, which was at the time a non-funded mandate. So that meant facility directors had to fit this into their existing budget without existing support. So all of this posed some significant challenges just from an implementation perspective. And back then, there really wasn't a great deal of support for assessing this. So we tried to undertake a stream of small research projects as well as some administrative work to get a better sense of what was happening. And I want to highlight one particular qualitative study and then one administrative database study that we did. So this qualitative study was published back in 2014, where we it was a comparative case study. We did visits to 7 different VA facilities that had chiropractic clinics and conducted interviews and reviewed policy documents. We specifically chose sites for some variation on early adopters versus later and geographic distribution as well as service lines. And we assessed, we conducted interviews with 118 stakeholders, the majority of which were physicians. We intentionally oversampled physicians, but also patients, the chiropractors themselves, and some administrators along the line. And then we also analyzed policy documents, particularly the facility policies and the clinical privileges for the chiropractors in question. We did a directed content analysis approach and came up with this conceptual model that we found, which I won't get into every detail on this, but essentially the context, the perspective of the facility when it was initially told that it was identified to be the site to add a chiropractic clinic had some bearing on the ultimate outcome. How the clinic was planned and implemented was varied greatly. And then the structures, processes, and outcomes we looked at in terms of the clinic itself, how the services were being delivered, and what were the impacts. We tried to see if there was a uniform way of assessing patient outcomes, and then we also looked at more system-wide outcomes. And I want to just highlight a few of the themes we encountered. So first, at the national level, we encountered some significant barriers back. This was when it was being planned in 2000, 2002. Here's one administrator who said that one of the big bosses at central office was totally opposed to the idea and said that he would have a chiropractic care over my dead body. And we knew that at that time there would be some significant resistance because of the historical disconnect between the chiropractic profession and medicine, and because of the fact that there hadn't been any real means of integrating to get a better understanding. We also found a barrier that had nothing to do with chiropractic itself, but was just what I mentioned earlier about the congressional mandate, that all government branches are often told by Congress what to do, but none of them like to be told by Congress what to do. So there's often this sort of initial bristling when a new law comes out and a government system needs to comply with something else, especially when there's not funding attached to it. So this we knew was another barrier that was facing the implementation. At the facility level, so if you were that was at national level at Washington, but if you were at a specific hospital, we saw a very mixed opinion. So again, some who perceived that this was just nonsense and had no place being in a hospital, and then others who had some positive perception based on either their understanding of the literature or what we've seen later, which was even a bigger harbinger of support, was personal experience. So that at any given hospital, there could be clinical leaders who had very divergent opinions on whether or not the facility is doing the right thing by adding this service. And the one most common determinant of support among clinical leaders was firsthand experience, either having colleagues or some type of experience with the chiropractors. And and we uncovered this in a number of interviews, and we've certainly seen it anecdotally many times across the system. And I was telling Dr. Wayne last night that this brings me back to, I heard Dr. David Eisenberg talk about 20 plus years ago, bringing up that very point that the biggest facilitator is that personal connection of understanding that one decision maker feels there's some level of confidence in the new provider type, whether it's a chiropractor or an acupuncturist or a Tai Chi instructor, that it comes down to having that experience more so than the data in some instances. We found that the clinics were implemented in various ways in different service lines. It was about half of the time in physical medicine, about a quarter of the time in primary care, and about a quarter in pain medicine, and it worked in all of those features. The characteristics of the chiropractors themselves that seemed to have a bearing on success was that the individual had to have a high degree of clinical acumen, that was expected, but have a scientific or an evidence-based background and be conversant in collaborative care, know how to manage cases collaboratively, but also just have some very simple collegial type of personality traits that made it easier for that person to walk into what was often a challenging environment with different levels of willingness among the other staff to collaborate. The patients that we spoke to were very satisfied with this. They were pleased that their VA facilities were delivering this service, but their only complaint was that they wanted more access. They often had very long wait times, and that was the one thing that we knew back in the early days, and we still face that to some degree as well. And then the physician themes, we specifically looked among medical or osteopathic physicians, and this was true among those who were referring frequently to the chiropractic clinic or never referring at all, that they had limited knowledge of what chiropractic services even were. But the ones who were referring were highly satisfied. They often said, I'm not exactly sure what he or she is doing, but the patients seem to like it, and I'm glad to have this as an option. And they anecdotally reported that they were prescribing less analgesics to patients when the chiropractic services were working, and they viewed that as a positive. But they also had some critique about the access and capacity, that it was hard for them to get their patients in. And we did see changing perceptions. So I brought up some of the negative perceptions that we knew existed, but we also measured some examples of a report of a changing perception. And this was an orthopedic surgeon who had been in practice for over 35 years, which is often challenging to change behaviors of folks when they've been in practice a long time. But this particular doc said that he knew chiropractors in town when he was in private practice that had a bad reputation, so he kept his distance. But then started working at VA. He'd only been there for a couple of years, and he started when there was a functioning chiropractic clinic, so he had that exposure of coming into the hospital where this was already a part of the system, and that enabled him to have that type of interaction. And now, even though he doesn't quite understand how it works, but just feels that it's reasonable because it was getting good outcomes and not doing harm. So this type of changing perception, changing perspective is something that we've seen in a number of instances. And that has translated at times to a willingness to look at other disciplines as well. So often the chiropractor was sort of the entry-level CIH provider, if you will, or the gateway CIH provider, and then the facility would be more willing to consider an acupuncturist or yoga or something after that. Not 100% of the time, but it often did serve in that capacity. And I guess because this is a small group, if anyone has questions or comments along the way, I'd be glad for you to bring them up as we go through each section. So now, part of our mandate in VA from the complying with the congressional authorization was to actually assess if we were delivering these services, because we knew that we had to meet the congressional mandate, but there was no model for the amount of penetration or the quantity of chiropractic care that what we could expect to have to be delivering in VA. So a lot of that was an unknown entity. And in addition to some managerial data, we looked at doing a research study using an informatics approach that was validated, searching VA's corporate data warehouse. Many of you may know that VA was an early adopter of EHRs, and a lot of data are captured, some of it very useful, some of it not so useful. But we have a very good handle on the types of services that are being delivered. So we published this in 2016, but what I'm presenting today are some updated data to that initial, pardon me, that initial paper. So in calendar year 2005, VA had met the congressional mandate of implementing at least 21 chiropractic clinics. And that green dotted line is the congressional mandate that has stood up until just recently, which I'll explain later on. So any growth above that was just organic growth of facilities in the system that decided to add this service after their experiences or learning from their colleagues at other facilities. And that growth has been fairly steady over the past 13 years. So currently there's just under 160 chiropractors working at about 97 facilities, and we're in the process of some additional expansion. So that is one marker of just organic growth and sort of diffusion of innovation across the system that's happened without any other congressional mandate and without any other funding appropriation. So we view this as sort of an indirect marker of program success, that it's being taken up and diffusing through the system. And I mentioned this, I think I mentioned these numbers before, but about half of the time the chiropractic clinics are in physical medicine and rehab, just under a quarter in primary care, about a quarter in pain, and then the rest are in various services. And these three service lines are the most, continually be the most common. This shows the dark bar is the number of unique patients that receive services in any given year, and the light bar, the number of visits or number of encounters. And it's grown on average of about 18% per year over that time frame. The absolute numbers are still small compared to VA's overall population. So we ended fiscal year 2018 with over 50,000 unique veterans receiving these services. But the growth of year after year is continuing, and we see that the utilization rate of about 4.6 visits per unique patient has been fairly stable. There's some reason to think that that may actually be on the low end. Some of the data on spinal manipulation outcomes suggests that a threshold dose closer to 12 might be appropriate for chronic pain conditions, but we don't have very good data on that right now. We're in the process of a couple of studies that are looking at that very feature. The conditions that chiropractors see in VA are what would be expected, predominantly low back pain, neck conditions, as well as some extremity and thoracic spine conditions. We see a higher proportion of younger veterans and female veterans, particularly from the current cohort of post-Iraq and Afghanistan conflicts. This is an important demographic in VA because they represent the future as the veteran population ages. And it's also important because this demographic is known to have a high prevalence of chronic musculoskeletal pain conditions and a high prevalence of mental health conditions. So looking to avoid opioid use in this population is important. The types of things that VA chiropractors do tend to be concordant with current clinical practice guidelines, things like spinal manipulation, exercise, et cetera. We also provide access by purchasing care in the community. So the blue bars show fiscal years 15 through 17, the number of veterans who've received care in-house at VA facilities. And then the red and green bars show two different mechanisms for VA to purchase care from private providers. We could forget for a moment that there are two mechanisms because they're being compressed into one. But you could just look at the back wall of this and see that in 17, roughly the same number of veterans received chiropractic care in-house at VA facilities as by purchasing care out in the community. And that blend of in-house and purchase care is the way VA is doing business in all healthcare across the country and will continue that way. But interestingly, we see some very different numbers of terms of cost. It looks like these are preliminary cost analyses, and they need to be done in a more sophisticated manner. But it looks like it's costing roughly twice as much per patient to send a veteran into the community to receive chiropractic care than what we deliver in-house at VA. And that runs counter to a lot of the prevailing political argument that VA is inefficient and it would be more efficient to spend the money in the community. So we're looking at this more closely. We could try to use this to model the development in the future. And we also see a wide variety in access. So I mentioned the 14% and 13% in terms of population access earlier on in the US about using chiropractic care. But in VA facilities, we're less, even though we're increasing the number of facilities that provide care, we're reaching a smaller percentage of the patient catchment of each facility. So we don't know what the optimal target is. It may not be the 14 or 13% that we see in those other populations, but we expect that it might be closer to 5 or 7% of the facility's catchment of patients that would be appropriate candidates. And we're assessing the better way to achieve that with some blend of in-house care as well as care in the community. So all of this talk so far is focused on the rationale for how VA began this program and the challenges and facilitators to implementing, and then just the ramp up or the growth of the services as they've been being delivered. And now I'd like to discuss some of the impacts and outcomes that we've seen. I have to preface this by saying that even though VA's EHR is robust in a lot of the data we can collect, there's not an easy system to collect patient-level outcomes data. The best system that we have that we know, and this is for any service, not just for chiropractic, is our system for sentinel events for collecting data on any serious adverse outcome. And so we've had about 1.6 million chiropractic visits in VA in-house since the program began, and there's been no sentinel event to date, so no serious harm. But in terms of doing a real deep dive in outcomes and assessing the difference between patients that see the chiropractic service versus those that might see other services treating the same low back pain conditions, we don't have that built in to our managerial data to be able to assess easily. So we've needed to implement some more sophisticated, some research studies to try to assess that, and those are in progress now. We have a little bit of data that I'll share, but any real hardy data comparing the differences and offset between chiropractic use and other things unfortunately doesn't exist. It's a little surprising that VA doesn't even have that for its existing services. So we don't know the difference between patients that see physiatry or neurology for musculoskeletal pain, or we just don't have it drilled down to that level yet. So in some of the challenges we face in assessing the chiropractic service delivery is just congruent with the challenges we face in assessing all services in VA. But nevertheless, we do have some information to share specifically about the chiropractic program. And because this is so timely, I thought it was worth just taking a little step aside and talk about some of the existing studies that have, pardon me, shown a negative correlation with chiropractic use and opioid use for patients with spinal pain complaints. So with some colleagues and I, we're actually working on a systematic review now that it looks like it's about a significant decreased likelihood patients receiving opioids for the spinal pain complaint, about a 0.48 risk reduction for if the chiropractic care is delivered versus if it's never delivered. And this has been seen in some large studies in employee health plans and workers' comp and in Medicare populations. We've also seen some studies that have shown a negative correlation with the use of other services for spinal pain complaints in DOD and workers' populations, and particularly in a private payer where we have VA has been collaborating with Optum Labs, which is the analytics wing for United Healthcare, and trying to learn from them on how they assess their use of different services. And we're trying to model some of that. And I have some slides from Optum that I have permission to share on how they've assessed chiropractic services delivery, and we're now trying to model that for VA. So this is a slide from Optum on 4 million non-surgical spine cases. This is data for 2014 and 15 for Optum, and they looked at all of the types of providers that their patients would see as an entry point for a non-surgical spine episode. And then this includes patients with all ranges of propensity scores of complexity. It was parsed out in all different, at all different levels of complexity. And the first thing that is interesting is they found about that chiropractors were the most common entry point in this population for patients seeking care for a spinal pain condition. And so about a little over 30% started with chiropractors, and the next group was primary care physicians. And then the bars on the right show the total cost, and as a payer, that's you could understand that United would be most interested in cost per episode. The total cost associated with an episode when the care starts with one provider. So on the right side, the blue bar is the cost associated with the provider that was the entry point. The green bar are other costs associated with that practice. So for instance, there could be physician costs and then maybe radiology costs all associated with the practice. And then the orange bar are the downstream costs for any other provider, any other service that patient winds up seeing for the low back pain condition, the spine pain condition. And in Optum's data, patients that start with either chiropractors or primary care physicians have the lowest overall costs, and particularly with chiropractors, the lowest use of downstream services. So the orange bar is the smallest, and again, this holds true across different levels of propensity scoring. So from a payer's perspective, the patients who see the chiropractic services earlier on in the spinal pain episode are less likely to use other healthcare services downstream. And this has been something that they've looked at in a very sophisticated way. And we're actually trying to model this same type of analysis now, looking across all of VA providers for low back pain, not specifically focusing on chiropractors, but trying to look at the same type of model. And in a capitated system like VA, cost offset or offset of other services is an important systems level outcome. When Optum drilled deeper to specifically look at guideline concordance, so non-surgical spine conditions that do not receive advanced imaging, which is guideline concordant, and do not receive opioids. So and this is in that same 4 million odd cohort, if the chiropractor was never seen, about 48% received advanced imaging and 13% received an opioid. If the chiropractor was the first provider, those numbers are much lower, only 26% for imaging and 4.8% for opioids. So this is not a patient-reported outcome, but more in terms of guideline concordant care or changing the frequency of services that are known to be less guideline concordant. And this too is an important measure of system performance, and we're trying to look at that same model as well. So while that work is in progress, we've done a smaller study on some existing VA data that relates to opioid use. Pardon me. And this was a cross-sectional analysis of the VA administrative data that we had from an existing cohort that specifically looked at the younger veteran population, those from Iraq and Afghanistan conflicts. We looked at the time frame of January 1st, 2004 through September 30th, 2014, and identified any veteran who had at least one chiropractic visit in-house in the system. And our main variable was receipt of an opioid prescription, filling an opioid prescription. We don't have any EHR mechanism to actually measure opioids taken, but we can measure prescriptions written or prescriptions filled. And most of the time, folks think that prescriptions filled is a better indicator of use, or a surrogate indicator of use. And then we looked at that plus or minus 90 days of the index chiropractic visit, and then looked at some demographics and other covariates as well. And we identified 14,000 veterans who had received, this is from the younger cohort, who had received chiropractic care. They were predominantly male and white, but that's actually much more diverse than the average VA population. The average VA population is about 90% male and 80% white. So the younger cohort is a little bit more gender and racially diverse, and certainly younger, a mean age of 38 years. And this cohort is different from VA's average, total population mean age is 65. This was a population that has significant illness burden of disease. More than half had moderate to severe pain and a diagnosis of post-traumatic stress disorder. Almost half had a depression diagnosis, and then about a third was smokers, 20% substance use disorder, and they were generally overweight. So this is generally, even though they're younger, they seem to be a less healthy cohort, and with a chronic musculoskeletal pain condition as well as chronic mental health conditions, the challenge is in sort of unraveling the interrelationship between both of those conditions and looking at some improvements in overall health status. So out of the 14,000, we identified a group of 4,300 that actually received an opioid, or that filled an opioid script plus or minus 90 days of the chiropractic visit. So about 30% of our population. And the likelihood of receiving an opioid was higher when the pain intensity was higher, or when there was a concurrent diagnosis of PTSD or depression. And this rate of about 30% receiving opioids is consistent with what's been published for the younger cohort with chronic musculoskeletal pain conditions. So at first we thought that this was really no different. So the folks that receive chiropractic care also receive opiates at the same frequency as those that don't. But when we looked at the timing of the opioid, we found something interesting. So in each of the 3 30-day windows before the index visit, the percentage of the population to fill an opioid script was higher than in any of the 3 30-day windows after the chiropractic visit, from just under 16% before to 11.5% at the lowest afterwards. And this held true across that time frame. So there could be potential explanations for this, that you could say, well, maybe it's just a trend of decreased opioid prescribing in VA, or maybe that these folks were initiated chiropractic care as part of a specific opioid taper so that they were going to receive less opioids in general. But it's a little hard to think that explains all of the difference in 4,300 cases. So we think that this gives some preliminary evidence that the use of chiropractic care in VA is associated with a decreased likelihood of filling an opioid script after the chiropractic visit. And now we're going to try to drill deeper into that because of the importance of that as a finding. And now just trying to take a little step back away from Chiro. As I mentioned, this was started back in 2000 for VA. And as the Chiro program was ramping up over those ensuing years, VA also began a larger effort on integrative medicine in general beyond Chiro. And you could see this in some of our policy documents that I've just highlighted number 3, that this has been in place for a very long time now, that VA's pain care aims to develop and integrate non-pharm modalities as part of the formal medical treatment plan, not as a sidebar. We recently, VA Health Services Research and Development held a state-of-the-art conference on non-pharm approaches for chronic musculoskeletal pain. The proceedings were published in a special issue of the Journal of General Internal Medicine. And one particular document looked at the clinical policy recommendations. So what was recommended as being supported by sufficient evidence at the present time that VA should be unrolling this widely were a number of therapies that are commonly classified as CIH interventions. So CBT, acceptance and commitment therapy, mindfulness, physical exercise, Tai Chi, yoga, acupuncture, manipulation, and massage. And it was stressed that these should be integrated early into delivery, into the course of pain treatment. And that dovetails with the United data showing that when you have the ability to give patients some non-pharm options that are evidence-based earlier on, then there's a less likelihood of them using other types of services that are less evidence-based or carry a greater risk. And this is something that that is a big step forward to see this codified. The challenge now is for VA to actually deliver this and actually reach the goal of providing this to a larger number of our patients. And just about coming to my last slide now, I had mentioned early on that there was a congressional mandate that started the chiropractic program, and then any growth occurred without any further mandate. And surprisingly, in 2018, another law was passed that no one in VA was expecting, but that required VA to raise its level of minimum on-station clinics. So what it boils down to is a tiered approach to growing the number of clinics, adding about 24 additional chiropractic clinics in VA hospitals by the end of 2021. And for the first time, there's actually an appropriations attached to that we're actually now have some funding to support the implementation of these clinics, but also to support the analysis from a programmatic perspective. And that's important because the law also specifically directed VA to include chiropractic services in its menu of options for preventive services. And this is something that right now we're not aware of any data to support the delivery of chiropractic services as a preventive measure and for primary prevention for any condition. But for secondary prevention, there are some, and I alluded to some before, that show that if a patient has a back pain condition, they may be less likely to use other services or potentially have recurrences downstream. But we don't have good data on what that would look like in terms of the patient profile who would be a candidate for preventive care or what the dosage of preventive care should be as well. So we're eagerly looking for interested investigators who would be interested in studying this, and we're attempting to model some of this just from an administrative perspective in terms of service delivery. So I think within the next few years, you will see a more rapid expansion of these services in VA. We have the we have a roadmap in place for implementing these services at facilities now that is fairly mature, and it's much easier for a hospital to now integrate a chiropractic clinic than it was back in 2004. And we see that also in terms of the willingness. Typically, back in 2004, if a facility would bring on a chiropractor, it would be one individual, one FTE, or sometimes even just a 0.5 FTE, just half of an individual. But now facilities are starting clinics by hiring 2 or 3 or 4 people at once to sort of staff it in a more robust way. And we're seeing that provide better access to the veterans, which has been one of the challenges that we've seen when you have a staffing model that's not as robust to the population. So we'll be seeing more of this, and looking, as I said, for ongoing partnerships with the community providers as well, because we will be doing more purchase care alongside of this in-house care. And I believe that was my last slide, and I think I'm just about right on time. And I know that Dr. Wayne wanted to structure maybe some other comments before we got into bigger Q&A.
Yeah. Well, that was fantastic. Thank you.
Oh, thanks.
Stay close. Okay. Yeah, and I know that Dr. Lisi is very welcome to questions. I was wondering if maybe for just one brief minute or so, Dr. Kowalski would want to say a word or two, because I think listening to this huge challenge of integrating a new modality into a complex system, the science, the policy, et cetera, and Dr. Kowalski has been on the forefront here at the Osher Center bringing chiropractic into Brigham and Women's Hospital. I wonder if you just reflect on Dr. Lisi's comments for a minute. Do we have a mic that?
I looked at your orthopedic surgeon's comment, 35 years in practice, and his experience with chiropractors, which is really interesting, because 35 years ago this couldn't have happened, to have a chiropractor standing at grand rounds at a hospital here. So that's a huge change. In fact, the cultural change that's occurred is pretty remarkable over the last 35 years. Harvard Medical School and Tufts Medical School now have programs that include introduction of chiropractic to all of the medical students going through the program. I teach at the program over at Tufts. And I asked the question about cultural bias and discuss some of the challenges that we've gone through. And most of the people there, most of the students there have no idea that there was a cultural bias. So it's an interesting shift that's occurred over the last, say, 30 years. And I want to thank you for what you've done at the VA in bringing the service to the service people that have cared for our country as well. So I think that's a great accomplishment, and really do want to thank you for that. But in the integration of chiropractic, I've seen that there's that administrative challenge, right? Administrative inclusion. There's a fiscal inclusion challenge, and then there's a cultural inclusion challenge. And so oftentimes chiropractors are winning, I see, on the administrative side. They're getting included in the clinics, and some of the clinics that are developing around the country. And the cultural part is probably the biggest challenge. And as you said, the chiropractors are commonly taken as an individual, and that acceptance is happening on an individual level rather than a professional level. And a lot of that's our own fault as chiropractors, and the cultural and social challenges that we have in the healthcare system. But the other one is, of course, the fiscal challenge, and the changes that we need to make within billing and providing care in the hospital system. And that, I think, has been one of our bigger challenges over at the Osher Center, and trying to figure out how you can cost effectively deliver chiropractic in a hospital. I know that challenge is kind of taken away when you're working under a different system in the VA system. Yeah. But I don't know if you know that Dr. Lisi actually recently did a study on chiropractors in hospitals around the country, and got to do a survey of a number of the hospitals and published a paper just a couple of months ago. It included Brigham and Women's Hospital. So what I would like to hear from you, if you can answer, is when you look at the other hospital systems that are out there and look at the VA, where do we diverge, and where can we learn from each other, and where are some of the challenges that you had that we didn't, and vice versa. So I'd love to hear what you learned about that as well.
Thanks a lot, Matt.
Thank you.
Yeah.
Sure. So you brought up the key point. I think the biggest divergence in the VA system being a capitated system that is under some tight pressures for provider FTE and a large number of patients. The addition of a chiropractic department is a very low cost in terms of the salary of the chiropractors, and because it's offsetting other costs, that's viewed as a plus. But not being in a fee-for-service model, it's very different when the chiropractic services are being reimbursed at a lower rate than other providers in the system, and then in that case, having that service in-house could actually be a loss leader, and that's what we've seen come up in some of the other private facilities that we visited, and that was a common theme. There were some hospitals that viewed this as that found a way to make it profitable, especially in those that had a complementary and integrative center, that the chiropractic services were one of the few that they could actually generate a profit on, where a lot of the other integrative services couldn't be billed. But then there were other private institutions that just viewed this as a positive for their population and were never expecting that clinic to actually cover itself. So, and that's a more complex decision.
Can I just add one thing and then open this up? I just want to say it's such a nice case example of how change happens or doesn't happen for so many complex reasons. We've got really practical issues of legislation. We've got cost policy issues. We've got culture changes that may happen one at a time. But we also have research, and I think the research that's happened, the evidence that's growing, that's still far from perfect, has moved things, but then the pragmatic cost effectiveness. And I think this is such a nice example of how all of those are slowly, to varying degrees, moving the dial both here. These are things we struggle at Brigham, but also in this big model of the VA. So, Helen?
Thank you. That was fascinating. Wonderfully presented. I'm curious about the Optum data that you presented. It was really amazing breakdown. The emergency department costs look really surprisingly low to me. Can you comment on that? And also, one thing, you would have expected these would have been some of the highest, right? And also, is there any thoughts about ever incorporating chiropractic care in emergency departments?
So I'll have to not be able to fully answer the first question, because I think what we saw in the Optum data on the emergency costs was that there were less downstream costs associated with it, and that might just be due to the way that the United Healthcare payers are dealing with back pain in emergency departments, but I don't have that fully answered right now. The second point is yes, there have been a number of instances in some VA facilities as well as outside of including chiropractors for the patients who are presenting to emergency department but who don't really have an emergency condition. They have severe back pain, but it's musculoskeletal. It's not an emergent condition, and that can offload the ED staff but I don't have data on that, but we do know that that's happened. Yeah. Yes, sir.
So that's a great presentation. Two questions. One is, are there similar policies of scope of practice across the nation, or is it at a VISN level or at a site level? And then the second question is, MDs, if they're hired by the VA, it doesn't matter necessarily what state you're licensed in, as long as, and is it the same sort of policy for chiropractic care providers?
Yes. So in VA, there are 5 what VA calls physician level providers. So there's MD-DO, dentists, and then actually it's MD-DO we count as one, dentists, than podiatry, optometry, and chiropractors. Podiatry, optometry, and chiropractors are sort of listed as a second-tier physician category, but that federal supremacy applies to all of those disciplines. So if someone is licensed in Massachusetts and they go to work for a VA facility in San Jose, that would, because they're on federal property, federal grounds, that would apply. And almost with every policy in VA, there's a national policy that is implemented very similarly across most regions, but there could always be some slight variation. But when it comes to the policies related to chiropractic, they're fairly standard across all facilities, all regions. Yes, Matt.
You indicated that departments that the chiropractors are placed in one of your slides. Was there one department that seemed to be more successful or one that was more challenging?
No, it's a good question. So this is something where the facility level variation, I think, is helpful, because we didn't have a national policy that said if you're going to add a chiropractor, it has to go into PM&R, it has to go here. We allowed the facilities to make those choices, and at times it was, in the initial group back in 2004, there were actually some facilities where PM&R stepped up and said, I want to do this, and then there were others that were just the only ones who didn't take a step back and got stuck doing it. But right now, it varies greatly. There's an increase in embedding other services in primary care to allow quick access. So that's why we see about 25% in primary care. The chiropractors are not functioning as primary care providers. They're functioning as chiropractors, but just being embedded right there. So, and then the other is pain medicine. So what we've seen is that how the prevailing clinical decision makers at any facility could make it work in any one of those, but it would be, it probably works best when that decision is made at the facility level rather than being determined from top down.
Thank you, Dr. Lisi. I'm a chiropractor in private practice, and are there any programs in place or any way that we can help gather data and provide to you in private practice?
So I appreciate the question. The VA has gone through an iteration in its processes for purchasing care in the community for everything, not just for chiropractic. When this program was initially started, Congress mandated VA to split its sort of funding mechanism, where certain amounts of funds were given to hospitals to provide care in-house, and another pool of funding was mandated that had to be purchased in the community. And that's the way it's being continued in the next appropriations. But the process for delivering that, for purchasing that care in the community at first was very haphazard, and we had very little ability to obtain data from community providers and share data. And we're in an iteration where that's attempting to be changed. So I believe it's going to be much easier for community providers of all disciplines to be able to share their data with VA and vice versa. So that, I would say, stand by for that.
Hi, thank you. Can you just walk through, if a new VA is going to add a chiropractic service or another chiropractor, what that looks like, the decisions they have to make, and how they disseminate that there's a new chiropractor and how to refer?
Well, the biggest decision is just that facility leadership agrees that this was an addition they want to make, and they have the budget for it. And then at that point, it comes down to recruiting and hiring the chiropractor. There's a standard process for that. In all VA jobs are posted through a standard federal government employee, I'm blanking on the word. Yeah, right, a website that lists open jobs. We have some national guidance for facilities if they've never done this before. If it's an existing hospital that already has a clinic and they're just adding capacity, then they probably have the expertise to assess a chiropractor, to select someone who's evidence-based and so on. But for those who are undertaking it for the first time, my office has a number of processes to help facilitate that. And then surprisingly, for getting the word out, or to sort of disseminate this to the local clinicians at the hospital, what we've seen is that it usually filters down through medical staff committee meetings to each department that this is happening, and that's really not a challenge in sort of making making it known that the clinic is open, and usually as soon as there is a button to click in our EHR that shows for consultation and chiropractic appears on the list, that there's a rather steady ramp up for referrals. So that doesn't seem to be a real challenge.
Dr. Lisi, great presentation. I just noticed that, as I say, in the VA system has hiring some acupuncturists
Yes.
as service providers. I'm wondering that your chiropractic program and the acupuncture program, they're separate, or they're one of the unit?
That's a great question. So because VA was mandated to begin chiropractic, as I mentioned, back in 2000, when VA did not have a program on complementary and integrative health. So administratively back then, chiropractic was put into what in our central office is called patient care services, which is part of sort of the standard all medical care that's delivered. But then about 5 or 7 years ago, VA began a complementary and integrative health as a new office, and that office is charged with overseeing acupuncture, massage, and other types of disciplines coming in. So, and that's led by Dr. Tracy Gaudet and Ben Kligler, who are both colleagues, and we collaborate very robustly. And a lot of the processes that we've used for chiropractic introduction, they've adopted for acupuncture. But in the VA administrative structure, we're separate offices, but we do collaborate very, very closely.
Well, I was talking with Tony on the way over this morning, and how the complexity of this task that he has now over close to 100 different centers where these processes are going on, and each unique center is not just science, it's not just clinical, but his time in Wall Street served him well in terms of the ability to manage complex portfolios of activities and administrative and leadership things. And so I don't think there's anyone more well qualified to do this. So I want to thank you for all your work, and it's really incredible, and I think it's quite pioneering, and I think it's relevant to many other academic hospital situations where we're working on these challenges of integration. So please join me in thanking Dr. Lisi for a great talk. I'd like to make a couple announcements. Of course, after each of these events, there's a little bit of a coffee snack area time for people to continue to network and talk to each other. But I also want to point out a few important events that are coming up. Of course, we have our network forum, our big conference that we do every 2 years, which is November 16th. And this one is centered around genetics, epigenetics, and lifestyle. And we have Dr. George Church doing the keynote, and it's a really rich panel of activities. So please pick up a flyer and see that. Our next Grand Rounds is also going to be really exciting. Many of you know Professor Ted Kapchuk, and his title for his provocative talk is called Making Placebos Honest, and he runs the whole Trans-Harvard Placebo Research Program. We won't have our January presentation, which would have been clinical because it's January 1st, and some people will be busy doing other things celebrating the new year. But we come back again on February 5th with another really interesting talk by Professor Vitaly Napadau, who's at Mass General, and he's on the forefront of using vagal stimulation that's gated by respiration to deal with a whole bunch of chronic pain issues. Some really interesting work from the physiological as well as the central nervous system. So that'll be a great talk on February 5th. So thanks again for coming, and hope to see you guys next week. Oh, wait. Oh, sorry. Forgot about November. And that's the flyer I have in front of me here. But one of our fellows who graduated and is now an assistant professor at Brigham and sleep disorders, Susie Burdish, is going to be leading a patient-centered grand rounds called Understanding the Role of Non-Pharmacological Treatments in Insomnia. So that's also going to be a really exciting talk. Sorry about that. And that's November 6th. Okay. We meet the first Tuesday of every month. Thanks for coming.